first ever webinar from the World Federation of Neuroradiological Societies. This morning's offering is entitled COVID-19 Neuroimaging in Real Life, an International Perspective from the WFNRS. So on behalf of myself, I'm Debbie Schatzkes, Lenox Hill Hospital in New York, USA, and my co-host, Dr. Choi-Sun Lim from the National Neuroscience Institute in Singapore. We welcome you. We are representatives from the WFNRS Education Committee, and again, this is an offering from the WFNRS. So our agenda for today is we will start with the review of the currently published literature on the CNS imaging findings of COVID-19. This will be from Dr. Lim. We will follow by the experiences from international members of the WFNRS societies. We'll hear first about the Chinese experience by Dr. Yao, followed by the Italian experience by Dr. Gervini, and finally the US experience from Dr. Filippi. I will give you a brief review of the published literature on head and neck imaging findings in COVID-19, and then we will do a question and answer session. And the way for you to submit your questions or comments is via the chat, and we will get to as many of these as we can, with the possibility that we may be able to address some of them offline as well. So just a few brief words about the WFNRS. So this is an umbrella organization, and it is composed of 37 national and regional neuroradiological societies. So for example, if you are a member of the ANRS or ENRS, those societies are member societies of the WFNRS. The mission is to foster collaborative international scientific and educational projects between its 37 member organizations, and these include travel grants for young or in training neuroradiologists. There are international outreach professor awards and a variety of educational offerings, and this webinar is an example of one of those. Probably most famously, the WFNRS is the sponsoring organization of the Symposium Neuroradiologicum. Now, this is a large international scientific assembly. It began in 1939, so it's been around for quite a while, and it meets every 4 years. The next meeting, the SNRS 22, will be at the New York Hilton Midtown. And it will occur May 13th to 16th of 2022. This is a wonderful, truly international meeting, much education, much science, and we hope we will see you there. So briefly, I think COVID-19 is clearly the disease that really needs no introduction. It has really had a grip on our planet. But as far as us as neuroradiologists, it's important to remember that the recognition of any neurologic manifestations of this disease came relatively late in the game, as initially certainly the pulmonary manifestations were the ones that were most in the news and were kind of eliciting the biggest response from the medical community. And I think many of us initially felt rather marginalized and kind of wondered, what could we do? What should we be doing? Some of us have contributed in various ways to, medical management, even outside of our field. But certainly, we were a little bit lost as to what we as neuroradiologists were supposed to be doing. But soon, there began to kind of trickle in various reports of neurologic manifestations. These were seen in clinical practice. They were being posted on social media. And then very early pre-publication data started appearing in some of our major medical journals. And the volumes of neuroimaging studies began slowly increasing. And I think this is as the complications, the neurologic complications began to become apparent. And now, as the pandemic has kind of plateaued or even started to recede somewhat, we are starting to slowly see increases in neuroimaging studies even outside of the COVID-19 forum. So I think it's fair to say that while we are still, and by we, I mean the medical community in general, are still struggling to understand what the underlying pathophysiology in the central nervous system is, I think imaging patterns have begun to emerge. And I think it's even fair to say that our recognition of these imaging patterns may ultimately really drive the clinical understanding of the impact of this virus on the central nervous system. So I think we are at a point where we have a tremendous amount to contribute. And we are really kind of at the pinnacle of our efforts to contribute to this understanding. So we will start off first with a review of the published literature on CNS imaging findings, and that will be by my co-host, Dr. Lim. So Dr. Lim, you can grab the screen.
Thank you very much, Debbie. So as we enter this pandemic, we don't start from a vacuum. In other words, we knew some information before the outbreak happened because of our understanding of past zoonotic outbreaks and the CNS effects. In the past, there have been many diseases that have jumped the species to infect man. These include known CT and MRI patterns. Now, we will also be viewing what we can see during this COVID-19 pandemic, whether these patterns are emerging in new situations or there are new imaging features that are being discovered. In the past, there have been zoonotic outbreaks, including Hendra in Australia, Nipah in Malaysia and Singapore, SARS in China and 25 other countries, MERS arising from the Middle East and spreading to 26 other countries, Ebola arising out of Africa, and now, of course, COVID-19. And in the past, we have had the misfortune in Singapore of encountering a few of these diseases. In the Nipah virus infection, there have been instances where the MR findings have shown tiny high signal intensities on T2-weighted MR images, some of them being high signal on diffusion-weighted MR imaging as well. And in the last multinational epidemic caused by the SARS virus version 1, there were descriptions of large artery ischemic stroke in a small study of 5 patients. In broad principles, viral infections and other infections can affect the brain by 3 broad categories of mechanism. Number 1 is direct CNS invasion by the pathogen, such as bacterial meningitis and herpes encephalitis, spread via the hematogenous or neural routes. The second large group is the indirect effects of immune system reaction, and these include immediate early immune reactions such as the cytokine storm described in acute necrotizing encephalopathy, or later immune-mediated effects such as ADEM and Guillain-Barré syndrome. Then there are a large category of effects on the CNS that may not be specific to a pathogen. These may include systemic disorders such as a coagulopathy state or stroke, critical illness effects such as hypoxic damage, comorbidities, as well as treatment and iatrogenic effects of long stays in the ICU or treatment-like drugs. As the pandemic has happened in the past few months, we have started to see publications, news, and opinion. The radiology department has had to deal with preparedness and PPE, protecting the staff, as you can see, the happy radiographers in the CT scanner. Many of these were informed by our previous experience. And here you see an article that was written by Singapore radiologists, which shared a very sophisticated French word, déjà vu, which means, oh no, not again. We're having another epidemic outbreak. So many of our practices are informed by our previous experience with SARS and others. Many of the publications also deal with, service changes, such as the total decrease in the number of cases that come to the radiology department, as well as opportunistic diagnosis of incidental COVID-19 in instances where patients present to the neuroradiology department for trauma or for stroke. And during CT scanning, the opportunistic diagnosis of undiagnosed COVID-19 patients becomes clear. There have been effects on teaching and research, and in neuroradiology, CNS symptoms as well as undiagnosed cases becomes quite important, but it's still very unclear what kind of mechanisms of damage are predominant in many of our patients. So I broadly categorized some of the published CT and MR literature that have been published in COVID and CNS, and they include several cases. And here you can see the names of the first author and the total number of cases described. And these include temporal lobe abnormalities, as well as abnormalities in the cortex, abnormalities of leptomeningeal enhancement, and ANE, like we described previously, and Guillain-Barré syndrome. Look how many patients have been described in large vessel and other kinds of stroke, and to a lesser extent, intracranial hemorrhage. Radiologists not only have to keep up with the imaging literature, but we also have to keep up with published literature outside of radiology. This includes neurology, stroke, virology, coagulopathy, and pathology. And these are some of the headline titles of relevant information that we have to be aware of. For instance, the virology in what the potential for neuroinvasion, the thrombotic complications and coagulopathy, and the conjunction between inflammation and infection. Finally, the pathology literature is very useful when post-mortem findings are described. There have been so many publications, some of them in the news, that the most recent AJNR article has been titled Cause or Coincidence. So we're not very sure exactly whether the virus is causing the CNS effects or its coincidence. The fog of war, as we're experiencing, makes this very difficult. So to present in real life, our speakers will elaborate on their experiences. And we will begin with Professor Yao, who comes from Shanghai, and he will share the experience in China. Dr. Yao, over to you.
Yes, thank you, Professor Lin. It's my great honor to be here to share our experience on COVID-19 in China and based on central nervous system. As we all know, this disease is first identified in Wuhan, China, and it mainly attacked the respiratory system. And now it's on its end stage in China, and even if there are more than 80,000 patients in China, but it almost ignored by Chinese neuroradiology. Yeah. Here it's the pictures of the widespread of all the world. Now it's the outbreak is in its end stage in China, maybe here, and this is America and Spanish, Italy. So it's this disease is worldwide spread, and is the cases is still rising now it's more than 4 million patients around the world. Here is several papers from China have described central nervous findings, include these papers. These two papers is very important. That's Dr. Mao. He give us the neurological manifestation of hospitalized patients with COVID-19 in Wuhan. And also the Dr. Li expand their experience on acute cerebrovascular disease following the COVID-19 in the same group. This paper have some results that's more severe patients had neurological manifestations include acute cerebral vascular disease. It's about 5% and impaired consciousness. Because, you know, to avoid close infections during the outbreak, acute cerebral vascular disease was diagnosed only by symptoms and head CT. So that's why there are only fewer limited MRI data in China. Atrial infarction and venous sinus thrombosis is the main appearance of these patients. It's a patient, the patient 2. This case, we can see the COVID-19 pneumonia here, and we can also see the infarction of right temporal lobe. And another patient demonstrate the hemorrhage within the frontal lobe and peripheral lobe. And we can also see the thrombus of the venous. Here is our cases in Shanghai. Also, it's a COVID-19 patient, and we can see some patchy low density areas around the lateral ventricle. But we don't know if it's acute or chronic infarction, because it's a 45 years old patient, and we have haven't MRI data. Here is a case from Beijing, Ditan Hospital, and they found their viral encephalitis patient in the hospital, and but there also was diagnosis by CSF with gene sequencing, but not from the MRI features. And many possible mechanisms of COVID-19 central nervous attack may be the virus have these 5 mechanisms like ACE2 and cytokine storm and calculatory passage, and also neural retrograde dissemination. They can induce the encephalitis and also the thrombus and ANE that's you described above. Here it's published on radiology. It's from America. We can see ANE in this patient. There are high intensity on the MRI in the cerebrums, And on CT, there are low density. And also we can find some microblooding and circle enhancement. So perspective from our opinion is it's not clear if CT and MRI findings in central nervous system in COVID-19 patients are due to virus itself or just complication of other organs dysfunction. Another thing is we find very few MRI reports in China. It's different from overseas clinical practice. Now, from literatures, we can find some MRI sign about COVID-19 patients from America and also from other countries. And because of overload of doctors' work and the economy burden, more attention must be paid on chest CT. So it's maybe the answer why there is fewer MRI in China. And but I think it's more effective for control of COVID-19 with a limited resource. So from my opinion, I think we must keep one eye on neurological it must play an important role on saving COVID-19 patients. Another thing must be more MRI features should be discovered in the future. So thank you for your very much for your attention.
Thank you very much, Dr. Yao. If there are any questions, please use the chat function or comments. So now we will move on to Dr. Simonetta Gervini, who is from Lombardy in Italy, and she will share with us the Italian experience. Simonetta?
Thank you, Choyo-san, for your introduction. This is the outline of my presentation. I would like to give you some epidemiological data. Some epidemiological data about the pandemic in Italy. This is a bar graph showing the situation in Italy on the last February. The so-called patient number 1, that's here, of this pandemic was discovered on 20th of February in Codogno, and from that point on, the number of new cases rapidly increased, leading to strict social distancing measures and soon after to the complete national lockdown. As represented in this figure, the virus was already locally circulating since the end of January. These are the current updated information about COVID cases in Italy by the 5th of May, and the total number that we have is 200,000 with the 40% of recovered patients, the 38% of patients at home isolation, and the 7% of hospitalized, only one requiring intensive care treatment. The deaths are around 40 of the total cases, 40% of the total cases. In Lombardy is the most affected region in Italy with a total number of 8,000 cases from the start of the pandemic. That is around the 40% of all Italian cases. In this other graph on the right, you can see that only a small number of COVID cases require ECU admission that represent less than 10% of the total of all hospitalized patients. Going to Bergamo, where now I work, this is to show you that at a certain point, that is here, the pandemic, in particular at the first week of March, in the number of cases abruptly increased in Bergamo and its province. My hospital, Papa Giovanni, is a referral hospital for patients coming from Bergamo and its province, since it is the largest hospital in the area. And from the beginning of the pandemic, more than 2,700 patients were tested positive in our institution, about 2,000 hospitalized and about 230 patients in ECU. In this group, only 45 of these patients had a fatal outcome. This is a recently published paper that it is just to see that 1,500 people of the hospital personnel were trained to face this emergency in 1 week. And all the ECU were reorganized to reach the total number of the beds to guarantee the mechanical ventilation support to those patients who need it. What we know so far about this virus, is this a neurotropic virus or not? As you have seen, what we know and the current knowledge is based on the evidence from other well-known human coronaviruses, SARS-CoV and MERS, that are proven to be neuroinvasive. And there is a recent paper from the literature who say that there is the possibility to find a virus in the anatomical specimen, brain anatomical specimen. This is just to summarize the main putative mechanism underlying neurological consequences of COVID-19. We have already talked about the cytokine storm, and I will focus on this part of the situation because there are other non-immunological mechanisms. First of all, it seems that the virus determines a procoagulative status, as proven by the higher incidence of thrombotic events on these cohorts, which show also increased dimer levels. Secondary, and again, it is very important to focus on that, in the severe patient, the long-standing hypoxia, in addition to hypotension and other aspects related to the critical care, could explain some part of the damage. These again are open issues. So we have to be very careful because given the high rates of COVID-19 infection in the general population, coincidental occurrence of neurological disease is likely, and we must be cautious about inferring causal linkages. However, we also must take into account that in this pandemic, neurological manifestation of COVID-19 may be overlooked at least the first part of the pandemic. Let's go to our findings. We evaluate a number of 127 patients with confirmed neurological symptoms. This means that all of them have been evaluated by a neurologist while they were hospitalized. So maybe the number could be potentially greater than that because other patients with non-specific symptoms, neurological symptoms, can have been at the moment excluded. The more frequent manifestation have been ischemic stroke and hemorrhagic stroke, followed by peripheral neuropathy, confusion, and disorientation. The majority of symptoms that we observe occur in the first stage in the early stage of the disease, around a week, 7 days after the infection. And there is another small percentage, 10% of cases, who arise with a late onset. The first choice in imaging this patient was a CT scan, and we evaluate 104 patients with at least a CT scan, and 44 of them have been studied with MRI. The pattern that we find was represented in the half of the cases by ischemic or hemorrhagic lesion, 25% presented with a sort of meningoencephalitis or meningitis, and around 30% of cases presented with other findings that we are trying to focus on that are represented by focal hypointensity on T2 and SY that I will show you in a while. CT was the first choice in imaging these patients because it has an high sensitivity to hemorrhage, a good sensitivity to ischemia. In addition, it is possible to design a protocol where CT is a one-stop shop exam, so the patient can do chest CT and brain CT together. Remember that there are a group of patients in which CT can be negative, being a false negative. Now I want to show you some few key representative cases from our series. This is a patient 67 years old with an history of hypertension presenting with aphasia. It was positive for chest CT and swab also. You can easily depict the acute ischemic lesion on the right side, and looking in the left side, there are some small other hypodensity, focal hypodensity that became more clear the day after. The majority of findings are represented by these findings, so around 25% of patients presented with ischemic or hemorrhagic lesion. This is another case who have also CT and MRI. You see it is a 61 years old patient with multiple ischemic lesion and small hemorrhagic foci that can be detected only if you add SVI. So behind the ischemic that is predominant and that can be easily seen on CT, if you add MRI, you can find something else. It is also to say that the majority of patients were around 50 or 60 years old, and the youngest that had an hemorrhagic presentation was 38 years old. This is another patient, 50 years old, with a past medical history that is unremarkable. He arrived with confusion that ended in a coma. He was a swab and chest CT positive. CT scan, brain CT scan was negative. Plain MRI was negative. With the injection of gadolinium, we can see leptomeningeal enhancement. We have around 10 patients with this presentation. This is a young female, 49 years old, with severe pulmonary COVID infection that required intubation for 1 week. After admission in a subintensive ward, she was clinically recovering when she presented with a mild left arm hyposthenia and an episode of falling and loss of consciousness. CT was unremarkable, so we decided to go for MRI. Just to clarify the use of MRI setting during this period, performing an MRI obviously is quite difficult, and it is not easy to be prepared to do that. In our facility, we have created 2 separated booths and 2 dedicated machines to perform COVID patients exams. So we have one machine that is clear and the other machine that is contaminated. Of course, there are strict room cleaning and disinfecting protocols to follow. And our personnel have been trained to deal with masks and respirators that have to be MRI safe, and all the protections devices were given, obviously. This case is particularly interesting because CT was negative, and when we performed MRI, what we found was the presence of these multiple foci of SVI hypointensity, both on supratentorial and infratentorial region with a dot aspect, but also linear. And we have a group of patients with this typical presentation. Also corpus callosum is involved. So when we try to reach pathogenetic hypothesis, we focus on the literature, and we pick up some papers who say that in patient with a severe anoxic brain injury, you can have a localization at the corpus callosum. In this patient that are reported in literature, edema is present. There is a restriction of diffusion. Also, brain edema can be associated. And so they are not so much similar to our patients. In some other situations, such as the critical illness associated cerebral microbleeds, there can be something very similar. But again, we also have involvement of the gray matter and supra and infratentorial region, also corpus callosum. So we don't know exactly what they represent. And there is another thing to say that only some of our patients were critically ill and on mechanical ventilation. So we have to recall the procoagulative status that seemed to be caused by this infection. And this is, for this reason, this is a very interesting paper from the literature in which the authors proved microthrombosis in the lung of the patients with severe COVID disease. And microthrombi information is the consequence of the activation of the complement related to the viral infection. So on a speculative level, we can imagine that microthrombotic lesions also can appear in other organs, such as kidneys, heart, and of course brain. And this can happen at the level of cerebral small vessels. But again, we are still in need of histological demonstration. On the right, you can see the viral entry uses the AC2 receptor expressed on several human cells and tissues. And it seems that the binding affinity of SARS-CoV-2 spike protein with AC2 receptor is 10-20 times greater than the other coronaviruses. And this can partially explain its greater virulence. Some other vascular-like disease, such as Kawasaki-like disease, are emerging on COVID-19 patients. And I just point out a paper recently published by our group. So there is something going on at the level of the small vasculature that needs to be clarified in more details. What about the future perspective? In a normal condition, there is an ideal circular pathway, a process of knowledge of a new disease, starting from a preclinical research and going to the community level. Instead, we are facing a situation in which things are coming out like part of the puzzles, and we don't understand really not so much about what it is happening. So we are facing something that is not clear, and we have to put together all the information to better understand what it is happening. The last consideration is about the possibility of the late onset of neurological manifestation of COVID-19, as have been previously described on human coronaviruses and other viruses in general. So we have also to focus on our patient now, and we have to follow up our patient to better understand what it is going on. And for doing that, we have to join together with the neurologists and to add to neuroimaging also other things such as neuropsychological tests, ENG, EMG. We have to be together doing this approach to the virus to better understand what it is going on. So in conclusion, I would like to leave you with this message to keep an open mind on this issue and try to equip ourselves as a medical professional with more possible tools, especially through the cooperation with colleagues and through the continuous support for research, because we have to understand better what it is going on. Thank you for your attention.
Thank you very much, Simonetta. That's fascinating findings of the corpus callosum. We see that in many different diseases, and I'm just wondering whether this is going to be one of them. So now we move on, like the pandemic is moving on, and we have the next speaker, Risto Filippi from New York City, who will describe to us the American experience. Risto?
We'll discuss now some of the central nervous system disease imaging findings, predominantly NMR, associated with the SARS-CoV-2 infection. I'll focus more on subacute to chronic findings. Thank you, everybody. So the coronavirus is a very serious virus. It's only been in the human population for 6 months, and if you ignore it, it'll be like a tsunami, and you do so at your own peril. This just shows you that in New York City, although we've been successful at flattening the corona curve, don't be fooled by the total numbers that you see, because the infection cases are still rising in the rest of the country. In New York City, we have about 5% of the world's population, but over a third of the world's cases. And we've had over 80,000 deaths, and some project probably over 100,000 if you account for unexpected death rates. And if we look at something like New York City, the death rate for 100,000 citizens, it's on the order of 137. It's greater than 100 in New Jersey and nearly 100 in Connecticut. These are all contiguous states in America. And to put it into perspective, the rate in Italy is around 47, so about 3 times higher. So we've had a much greater burden of disease. Some operational considerations. If you can sequester 1 MR for COVID imaging of the patients, that may be more ideal. You still have to engage in cleaning the room after every patient is imaged. A lot of the patients are ventilator and encephalopathic and not communicative, so they could be moving, and you may need to shorten protocols. And when you're doing other kinds of routine imaging in an ER patient, you may detect unsuspected COVID infection, and make sure everybody has protective equipment. And the pathology, all I will say is that the ACE2 receptor has a key role, and it's everywhere in the body: nasal mucosa, GI tract, organs, the central nervous system, both cortex and brainstem, as well as endothelial cells lining arteries and veins. This is why it's such a poly-organ, polysystemic disease. And interleukin-6 is a pro-inflammatory mediator and probably has a role in the cytokine release storm. And in our New York City experience, we've imaged 202 patients, and 157 have had positive scans. We are sub-selecting. There's a bias there. People who are the sickest get the scans, and people who are less ill do not get the scans. And the age range, as you can see, is 25 to nearly 95. There's a bit more of a male predominance, which is in keeping with republished literature, stating that men tend to do a bit worse with this COVID infection. These are our numbers. We've seen a lot of non-hemorrhagic and hemorrhagic strokes, venous infarcts with thrombosis, many different kinds of hemorrhages and large vessel occlusion. In the more subacute to chronic cases, interestingly, we're seeing a pattern of hypoxic ischemic injury, anoxia, encephalitis, and a process by which we may invoke a thrombotic microangiopathy. And some of the acute cases that we've imaged really center around infarction, which is well known. So we'll look at some of those images immediately. And many of these patients are quite young, but we don't really have any risk factors to explain this or genetic factors, but maybe there's something that we haven't yet elicited. The classic right MCA territory infarct on CT and MR, and no susceptibility on the gradient echo, a case of a classic hemorrhagic lesion in the right temporal lobe, a venous hemorrhagic infarct with occlusion of the transverse sinus and sigmoid sinus. And then another person in their mid-50s with no comorbidities demonstrating bilateral MCA occlusions and multi-level thromboses in the M1 segment of the right MCA and the M1 and distal M1 segment on the left and proximal inferior division of M2, and of course, cutoff signs bilaterally in the MCA territory on the CT angiogram. And then we have cases like this who look relatively normal on a CT scan in a much older patient with all kinds of comorbid conditions, who then has an MR on the same day, and there's like this extensive watershed territory infarction bilaterally. And we have had many cases of multifocal hemorrhages, as in this case, with cerebral edemal, sulcal effacement, pending herniation, and bad outcome. And then others that are more focal, isolated subarachnoid hemorrhage with no etiology elicited to explain that focal hemorrhage other than the COVID infection. And we talk about CNS entry. Is it just hematologist? Is it direct invasion? Is it retrograde neural spread? We do know there's endothelial damage, which may have some role in the coagulopathy and prothrombotic states. Others are talking about a sympathetic storm causing seizure and encephalopathy in 5 to 10% of ICU patients. And in the chronic phases of their hospitalization, we are imaging more of these patients as they are extubated and encephalopathic or not being weaned from the ventilator effectively. And we are showing some of those patterns to you currently on the following slides, and things like anoxic injury, white matter injury, whether it's post-anoxic leukoencephalopathies from hypoxic ischemic process will be discussed, and we'll show some other examples of encephalitis and press-like patterns. So here's a case where you have bilateral symmetric T2 prolongation, there's reduced diffusivity and susceptibility, and it's very bilateral, it's very symmetric, it's press-like in its distribution, and again, showing you the abnormality on DWI, the hypointensity, the ADC map, and some T1 shortening, cortically indicative of subacute methemoglobin, and whether this represents a combination of you can get infarction in press-like syndromes. This is one of several cases that we've seen. Another example, status post-extubation with continued encephalopathy and EEG abnormalities, demonstrating this more classic pattern of subcortical white matter edema that doesn't demonstrate diffusion reduction or just restricted diffusivity. But interestingly, and a pattern that is reminiscent of the Bergamo experience, where you have microhemorrhages in the splenium, these other areas of microhemorrhage that are sort of along the corticomedullary junction, and they may represent microthrombi, which has been reported pathologically. So maybe this is a kind of microthrombotic angiopathy in association with press. And it's really quite exquisite, these areas of abnormal susceptibility that are really periphery at that corticomedullary junction. Here's another example that we see. Dual pathology happens quite often. We have many patients with this kind of T2 prolongation and deep gray nuclei indicative of anoxic injury with punctate white matter infarcts. And then we have another example of sort of diffuse white matter injury with concomitant punctate deep white matter infarcts. And these patterns are, quite extensive in the white matter, and we have many cases like this. Here's another example where, again, we have this sort of diffuse white matter hyperintensity that's restricting on diffusion with some punctate superimposed white matter infarcts. Is it a combination of an anoxic leukoencephalopathy with a thrombotic microangiopathy? This needs to be elicited and worked out. Another example of, again, this pattern of diffuse white matter injury. And again, just a nicer example of these really punctate areas of susceptibility, sort of paralleling corticomedullary junction, a larger focus there, and corresponding flare image just showing you the diffuseness of this leukoencephalopathic pattern. And another example, again, encephalopathy for more than 2 weeks. And again, just involvement of the hippocampi nicely with this white matter abnormality. And again, sort of more punctate micro susceptibility foci. Some of the white matter patterns of injury are really symmetric, almost demyelinating in appearance. We have others that almost look like ADEM, but these may in fact be ischemic, and we just don't know because we have cases like this where we may have presumed sort of a demyelinating process, but when we look at CSF, we don't have anything to support an ADEM diagnosis currently. But here you have bilateral symmetric abnormal T2 prolongation on the cortical spinal tract, splenia and brachium pontus, and here's another example of abnormality that we are still trying to come to consensus on what this represents, because you have an area of hemorrhage and vasogenic edema, but there's a lot of cortical abnormal reduced diffusivity far beyond the margins of that one larger area of hemorrhage and edema, and this restricts diffusion. And is this some hemorrhagic encephalitis that's been reported? We are still awaiting final consensus. And then over the weekend, we've had several cases come through with a cerebellar inflammation pattern, one of which led to herniation and demise in a very young patient under the age of 50. This was an older patient with comorbidities, but again, this sort of exquisite cerebellar inflammation, we're not really entirely sure what elicits this response. So, you know, in summation, a lot of the patients who've been on ventilating support for more than 2 weeks develop encephalopathy with EEG abnormality, and we're finding a pattern of injury that focuses on white matter with diffuse leukoencephalopathy, as well as these areas of susceptibility that are very tiny along corticomedullary junction, corpus callosum, perhaps involving deep gray nuclei, as well as other more atypical patterns of press and cerebellar inflammation and other patterns that resemble an ADEM picture. And some concluding thoughts. We know that there's a lot of central nervous system involvement in patients who have a severe infection with SARS-CoV-2, and it's an evolving story. Acutely, it's been well documented from the Chinese experience and in Bergamo that there's stroke, thrombosis, hemorrhage, and large vessel occlusion. What's interesting now is the evolution in subacute to late findings, which are focusing more on patterns that are more reminiscent of hypoxic ischemic injury, white matter injury like post-anoxic leukoencephalopathy, these kinds of micro susceptibility foci, which may be thrombus or hemorrhage, more along the lines of micro thrombotic microangiopathy, almost like a high altitude pulmonary edema pattern, and again, encephalitis and press. The long-term sequelae on patients clinically is unknown, but being encephalopathic post-extubation, given the numbers of infections that we are witnessing, portends difficulty in the months ahead in terms of how to care for these patients long-term and what that means to healthcare delivery. And there's still far more questions than answers regarding pathophysiology. Thank you very much for your patience with my technical glitches, for which I am very apologetic. And thank you for this kind invitation to share our experiences. And as Simonetta and the others have said earlier, I think that this is a great moment for all of us in neuroradiology to really reach across the aisle and to share our experiences and to work together to understand more fully the neuroimaging patterns of this disease and its consequences on the central nervous system so we can take better care of our patients going forward, because COVID will be with us, I think, for the next several years. Thank you all very much for your attention.
Thank you very much, Risto. So we will conclude the didactic portion of this with a very brief discussion of the head and neck manifestations of COVID-19. And I think it's pretty clear that, you know, just as the neuroimaging took a backseat to pulmonary and other clinical manifestations of the disease, head and neck imaging has really taken a backseat and still does, because there really are not many significant head and neck manifestations, but 3 topics have emerged. The first is olfactory dysfunction, I will abbreviate it as OD, cranial neuropathy, and a newly recognized entity, a pediatric multi-system inflammatory syndrome. So olfactory dysfunction in COVID-19 is a famous symptom, but also has become increasingly recognized as a predictor. This is a review article published in the American Academy of Otolaryngology Head and Neck Surgery with kind of a compilation of many of the published papers on this topic. And two very interesting findings, one from Dr. Lushin et al., showing that almost 90% of COVID-19 patients have olfactory dysfunction. This was from a large multi-center European analysis. But also cited in that paper is data from Dr. Salmon et al. That shows that 95% or so of patients with sudden olfactory dysfunction, but no other nasal or respiratory symptoms of COVID-19 did ultimately test positive for the disease. So that's, you know, some very tantalizing data, and many head and neck imagers, including myself, thought, well, this would be a great idea to look at the olfactory apparatus on MR in these patients. But I think it's important to recognize, and I think it's summarized in this statement from this paper, that advanced imaging is unnecessary, especially since a large proportion of patients may experience improvement of olfactory dysfunction with resolution of COVID-19. So while we may be interested in what this looks like, it really is not of clinical relevance. So there has not been much published on imaging findings. There were 3 case reports of olfactory dysfunction that included MR imaging, and in 2 of 3 of those cases, there were no findings. These images are from a case report published in JAMA Otolaryngology on April 8th. And you can see we've got coronal CT and MR images showing that there is relatively symmetric lobular soft tissue density in the superior nasal cavity and the olfactory recess, kind of intermediate signal intensity on these T2 weighted images. And many of us saw that and thought about another entity, and these are 3 of my slides from a lecture I do on sinonasal imaging, and you can see that the findings are virtually identical. Again, lobular soft tissue in the olfactory cleft bilaterally, kind of intermediate signal intensity. And this is REA, respiratory epithelial adenomatoid hyperplasia. So that, I think, reminds us that, you know, given the prevalence of serologic positivity now for COVID-19 in the population, you know, people who have other problems are going to be imaged. And of course, as has been discussed previously by our other speakers, this does not necessarily imply causation. But I will present some pre-publication data from colleagues at Weill Cornell Medicine, New York Presbyterian Hospital, and they're actually doing a retrospective, blinded and controlled study of 22 patients imaged with COVID-19 and olfactory dysfunction. 5 of them show T2 hyperintensity in the olfactory apparatus. So these are images of a normal patient. These are 3D contrast enhanced flare images, and you can see essentially iso-intense signal in the olfactory apparatus, and the internal comparison is to the trigeminal nerve. And in this COVID-19 patient, there is relative T2 hyperintensity on these coronal images, and sort of nicely demonstrated on these oblique sagittals. So, you know, there may in fact be a correlation on imaging in some patients, but it is very subtle. It's also very difficult in patients who are sick to obtain images with sufficient quality and sort of lack of motion artifact to even be able to see these subtle findings. So we'll see. The other topic is cranial neuropathy, and as Dr. Simonetta reported in her talk, there are sort of emerging reports of cranial neuropathies in this patient. One specific report in neurology, 2 patients, one with Miller-Fisher syndrome, the other with polyneuritis cranialis. Fisher syndrome is a Guillain-Barré variant with acute onset of ophthalmoplegia, ataxia, and loss of tendon reflexes. And the second patient had several cranial nerves out, including, I believe, oculomotor nerve. So these patients were both tested negative in their CSF for COVID-19. And I think the postulate is that this cranial neuropathy in the setting of COVID-19 is likely an immune-mediated either para or post-viral neuropathy, again, similar sort of within the spectrum of Guillain-Barré syndrome. And this case was sent to me by Dr. Van Rensburg. This is a patient, COVID-19 positive, who presented with bilateral cranial 7 neuropathy. You can see the abnormal enhancement in the distal IAC, labyrinthine segments, and geniculates. This actually continued downward towards the mastoid segments. Again, this patient clinically was felt to have GBS. So I think we mostly believe that this is not a direct viral infection, but rather an immune-mediated response to the infection. And then finally, relatively hot off the press, this is a release from the New York State Department of Health that was sent out on May 4th. Health alert number 13, pediatric multi-system inflammatory syndrome potentially associated with COVID-19. At that time, 15 cases were reported of patients with this multi-system inflammatory syndrome in New York City hospitals. This has now increased to over 60 as of yesterday. So this entity, and this is actually the full name of this entity, pediatric multi-system inflammatory syndrome potentially associated with COVID-19. Kind of hedging there, but I think there's a strong belief that it is in fact associated with COVID-19. This was first reported in The Lancet, published on May 6th with 20 patients. The clinical features are very similar to Kawasaki disease and toxic shock syndrome. Kawasaki disease is also known as acute infantile febrile mucocutaneous lymph node syndrome, and it is a self-limited vasculitis with the clinical presentation of fever, rash, conjunctivitis, and GI, and most importantly, cardiac complications. And these cardiac complications lead to the greatest morbidity and mortality in this disease. Now, it is important to know that the PCR test for COVID-19 has been shown to be either positive or negative in this patient, but now that we have increasing serologic testing, they have virtually all been positive for antibodies. Now, as far as manifestations important to us as neuroradiologists, in the head and neck, these patients can present with cervical lymphadenopathy. Remember that the original Kawasaki disease has the name lymph nodes syndrome as part of its title. And then there is one reported case of cerebral infarction in the setting of this syndrome, which of course makes sense being that it is a vasculitis. And now that this is being reported more and more in the lay media, there has been just kind of widespread increasing kind of panic about the fact that our children who were thought to be relatively safe as far as serious complications of this disease may in fact not be so. So let me show you a case. This one is courtesy of Doug Phillips. This is a 20-year-old male patient with COVID-19 presenting with classic Kawasaki presentation, rash on the feet and hands, chest pain, and neck swelling. You can see the enormous right cervical lymph node. This is an enlarged tubal tonsil. And I want you to also notice that there is retropharyngeal edema, and edema is an important manifestation of this disease. So I think that that is pretty much the summary of the head and neck manifestations, as well as the didactic portion. And I'm going to turn the podium, as it were, over to Dr. Leon van Rensburg from South Africa, and he's going to present some of the questions and comments that have emerged in the chat function. So Leon.
Good afternoon from Cape Town, everybody. Can you hear me?
Yes, we can.
Yes.
Okay. Our first question is from Dr. Francois Cotton, Lyons, France. And the question is for Dr. Simonetti. He wonders about the pathophysiology of microbleeds under subcortical and corpus callosum in diagnosed encephalitis patients in the ICU.
We are not sure about the pathophysiology. We think that it can be related to the modifications of these patients during the respiratory failure. So we are trying to put together all the data coming from the ECU, but not all the patients have been in ECU, first of all. Second, I think that there are some differences that are not so clear because you have a plain CT scan negative, so no hemorrhage there. You have gradient echo sequences that are negative. You are only able to pick up the T2 hyperintensity on SY sequences. So we should think, we can think that they are thrombus or something like that, and not a true hemorrhage. But anyway, we are not sure about the meaning. And second, we don't have edema, nor brain edema, neither edema in the corpus callosum. But sometimes we have small foci of restriction of diffusion where there are the hypointensity on SY. So maybe something of vascular origin is there, but I don't have a correct answer. I don't know exactly what they are. Maybe Risto can add something.
Thank you very much.
Yeah.
Any comments from any of the other panelists?
I mean, I would just echo what, you know, I would just echo those comments that I concur that we are seeing in subacute to chronic patients this pattern of diffuse leukoencephalopathy with concomitant abnormalities, and we see them on gradient echo at our 1.5 Tesla machine. Again, very punctate, predominantly corticomedullary junction, but also in corpus callosum. And you know, we're thinking it's a thrombotic microangiopathic process, but we still don't have adequate proof. Autopsy is exceptionally difficult to obtain because we are overwhelmed with capacity, frankly, and we have to just wait for those. But that's just the current thinking given the degree of ACE receptors and smooth muscle walls of arteries, as well as endothelial cells of arteries and veins, but still conjecture at this point.
Thank you. Our second question comes from Dr. Jose Carlos Ryan Aledo from Alicante, Spain, and this is for the panel. Thank you for the talk, Dr. Gervini. Have you or anybody in the panel observed delayed thrombotic symptoms, i.e. 1 to 4 weeks post-negative PCR? He has heard about at least 2 cases, one including central retinal artery 1 week post, and the other with a deep venous thrombosis and pulmonary embolism 4 weeks after a negative PCR.
Yes, we also have experienced retinal thrombosis in some patients after 1 month, not 1 week, but not cerebral thrombosis in my sample.
Anybody else from the panel? Okay, third question is from Dr. Nozani Rose Maud Zain to the panel. Many of the findings described in COVID-19 patients have also been observed in other viral infections in Malaysia, most notably dengue viral infection. Could it be that the mechanisms are not only specific to COVID infection, but common to most viral infections? Would you like to take that?
Yeah, I can say that you're right. There are other zoonotic and epidemic as well as vector-borne infections, and many of the viruses seem to have some fairly common endpoints. For instance, we've seen in the past outbreaks that there can be endothelial damage, microvasculitis, and microthrombi. So there may be leading to microinfarcts in the brain, which might explain some of the very, very tiny high signal intensities on DWI that Risto showed and which we had seen in other outbreaks before. So I think there is some kind of a common pathway, except that we don't know enough about it, which is one of the reasons why I think we probably need to read outside the literature and have as many multidisciplinary meetings with the virologist, hematologist, neurologist as well. So I don't know how the others in the panel feel about this, but we find these meetings to be extremely helpful, and it guides us a little bit along the way, even though we don't have a unifying theory at this moment.
Thank you, Tyson. Anybody else? Okay, next question is from Dr. Caroline Robson, Boston. To everybody, has anybody or anyone seen extracranial head and neck manifestations in children looking like cellulitis or fasciitis with a hyaluronidonitis and large beard-like phlegmonous fluid collections?
I can take that. Actually, Callie and I have been texting separately during this conversation about the topic. You know, this is our modern multitasking world. We have seen a couple of cases at Lenox Hill Hospital, but we have not necessarily made the association or certainly the causal association with COVID infection. We have just assumed that these patients have had, diffuse sialadenitis from other causes. But of course, we're familiar with, measles and mumps causing diffuse viral sialadenitis from a hematogenous standpoint. So I suppose just like, cranial neuropathy, we should not be surprised if it does turn out to be a virus that can cause a viral sialadenitis. So Callie and I are talking about pooling some of our cases and trying to collect some. And if anybody who is listening has any, please respond in the chat. Or there will be an email address for the WFNRS given to you at the end. And if you are interested in collaborating on looking at these cases, we would certainly appreciate the more the merrier.
Thank you, Debbie. We have a question from Dr. Karen Miller. I don't know where she is from. To everybody, we have one case, a 10-year-old presented with abdominal pain and mesenteric adenopathy on CT. So
this is a case of the multi-system
yes.
disorder. So yes, they are starting to pop up. And again, I think, they probably have been happening for quite a while. But the association with COVID-19, now that it is being publicized both through, medical communication as well as through the media, I think the case numbers will start to increase just because of the fact that we now know. Of course, they could be increasing now because it is a later disease stage manifestation as well. But now that these cases are showing up, we will hopefully have the opportunity to learn more about them and their association with the virus.
Thank you, Debbie. A question from Dr. Mustafa Hizal to the panel. Are there differences in CNS findings between swab positive and negative patients? Do any of you have any experience about this?
I'm sorry, I'm not sure to understand correctly the question.
Well, the question is this different CNS manifestations in patients that are then PCR positive and negative, but if it's negative, I think we need to know whether the patient later on become positive. So I'm not quite sure
I thought
you really answer that.
It is not for cerebrospinal fluid is just swab. Okay.
Well, yeah.
So if
Any
it is
further
swab
comments
negative,
on that?
if it is swab negative, it is not supposed to be COVID plus.
Yes, so we need more information on that. Then from Dr. Hannah Larasati to the panel, how do you manage your MRI service in your hospitals? Do you dedicate an MR suite for COVID-19 patients, or do you just sterilize the suite after being used by a COVID-19 positive patient?
I mean,
In our
I guess I could start with that. I think there's no one size that really fits all. And I will say that it's a process of evolution, depending on the people with whom you speak. For many of the hospitals at the height of the epicenter, at the peak, there just wasn't any capacity to do imaging. We were overwhelmed with converting 11 floors of a hospital to all being ICU beds and COVID beds. So as time wore on, we opened up imaging to patients. We did dedicate a single MR scanner for COVID positive patients, but it still needs to be cleaned in between because you have staff and technicians, even if they have N95 masks, still need to be really careful. So you still have this process of cleaning in between COVID positive patients. And I think the bigger question now in this subacute to chronic phase as we evolve to opening up the hospital again to all kinds of patients who need care, including outpatients, we have to think harder about how best to do this. It may not be feasible to have a dedicated CT or MR or ultrasound unit to COVID positive only patients, so we will have to rely upon more stringent sterilization and cleaning measures in between cases. And for that to happen, because you want to have increased throughput and clinical operational efficiency, we may need to sort of abbreviate some MR protocols. Is there a way to sort of nuance this that you can get the greatest good for the greatest number of patients? And it may mean changing some of our protocols to affect, to increase capacity in effect. I'll let others speak to their experience.
Any other comments from anybody? Thank you very much. Sorry, yes, please.
No, I agree completely with Risto, because at the beginning of the pandemic, we split the machines. One was completely for COVID plus, and the second was for other patients, but other patients didn't come at the beginning. So everything was for COVID patients. Now we are going down with the numbers, and so we are trying to approach in a different way, and it is correct. We should select a dedicated protocol for COVID patients and moving on with the others.
Thank you very much, Simonetta. Our last question, time doesn't allow any more questions. For those of you who still got questions, we will answer them by email. It is from Dr. Joanna Tay in Singapore. And the question is to Dr. Gervini and Filippi. Did you check antiphospholipid antibodies in the patients with thrombotic strokes or suspected thrombotic microangiopathy?
Yes, and they are not all positive. Some they are.
Maybe and I'm sorry, Dr. Jeremy, I did not mean to cut you off at all, but yes, exactly the same experience. We do test for all kinds of factors. Alpha or antiphospholipid antibody are present in some and many, but not all. And so there's not a one-to-one sort of correspondence. And this is what makes coronavirus so intellectually fascinating and challenging to us all.
Okay, this concludes the answer and question session. Thank you very much for that very enthusiastic participation. And I'm handing you back to Dr. Thijssen.
Thank you very much, Leon. So as we move into the pandemic and hopefully come out on the other side a bit better, there was a very good editorial in the AJNR which highlighted that this is the first time the entire global community of neuroradiologists is learning about a new disease as it unfolds in real time, in real life, right in front of our eyes. And it's important for us to learn as much about the information so that we can take care of ourselves, our patients, and the community around us. When this editorial came out, I was very moved to write a letter to the editor.
We cannot hear.
I'm sorry. I thought it would be important for us to have solidarity all around the world because we are involved with mankind and all of us are linked and no man is an island. And here are Chinese, Latin, and English phrases that have the same sentiment, but in different languages, showing us that at heart, we are all the same. And before we say goodnight, I'd like to invite the president of the World Federation of Neuroradiological Societies, Dr. Turgut Tali, to say a few words. Turgut?
Thank you, Choyson. Can you hear me?
Yes.
Okay. I would like to convey my sincere gratitude to all the speakers, moderators, co-hosts, and organizers of this webinar on behalf of the Executive Committee. Can I have the next slide, please? Okay, very good. So, as Dr. Shatkes mentioned previously, our educational activities will continue. Would you please follow us by www.wfnrs.org and from Facebook, World Federation of Neuroradiological Societies, and Twitter, World FNRS. Thank you very much for your attending this nice webinar.
Thank you, Turgut. Let's bring this webinar to a close on behalf of my co-moderator, Debbie, and the entire WFNRS team. Good night, good morning, and most important, good health. Until we meet again, goodbye.
Bye-bye.